Hi, I'm Christine Fair. Thank you guys for tuning in to this discussion about the second wave of COVID-19 in India and beyond. For much of 2020, it seemed as if India and its neighbors had really defied many of the expectations of the deaths and chaos that many observers of South Asia had expected. And in fact, many Indians thought that the pandemic was actually behind them. Then all of a sudden, in March of this year, the sort of sanguine expectations of what was going to happen in India dramatically began to change. And let me just very quickly show you a map or some data on what's going on in India. And then I'm going to just very quickly give you an overview of what's happening in the neighborhood. So this is one view of the COVID cases, looking at the average daily cases for the various states across India. So the first thing you see is, India is a very large country. Healthcare in many ways is devolved to the state. So we would expect there to be different outcomes. By the way, I'm pretty sure there'll be future dissertations written on how different conditions in the different states produce different kinds of outcomes with respect to COVID. When we take a look at the neighborhood, right now, India is getting a lot of attention. That's in part because, the West has long had a fascination with India. But some of its neighbors, like Nepal, are actually experiencing even graver fatalities with COVID. And there's very little attention given to Nepal. So much so that the Prime Minister of Nepal actually felt compelled to write an op-ed saying, hey, look north, we need your help too. A few weeks ago, I got a letter from the ambassador of Bangladesh. He was saying, again, everyone's focusing on India, but hey, Bangladesh needs help as well. And Sri Lanka is also fighting really hard with this second wave of COVID. Curiously, Pakistan seems to be, I would say, one of the best positioned countries in the region. It has not so far experienced the brutality of this wave. So here, to discuss the second wave of COVID in India and beyond, we have a really well-qualified set of speakers. The first person that is going to be speaking is Cecilia Van Hollen. So she's a professor at Yale NUS College in Singapore, and she's actually a visiting faculty member of the STIA program here at Georgetown University. She is going to open up the discussion by talking about some of the systemic problems with the ways in which India delivers healthcare. So while there's been a lot of criticism at the political level, what this particular pandemic has really exposed were historical problems that have given rise to some of the lethality that we're currently observing. Shireen Joshi is an associate professor here at Georgetown in the Walsh School of Foreign Service. She is going to be talking about the problems with data. What kind of data do we have? What kind of data do we not have? And in a way that will be very familiar to many Americans, the ways in which the use and even existence of data has become highly politicized. For those of you that are watching arrests that have taken place in India of journalists who have dared to present science suggesting that cow dung is not a cure for COVID, this is going to have a very chilling effect on the discourse around what is efficacious against COVID and what isn't. And then Jishnu Das is going to conclude this panel prior to opening it up to Q&A. And by the way, I would really like you to use the Q&A function when Jishnu wraps up his presentation. He's going to be talking about some of the work that he and his team have done on the COVID crisis in India, actually for the duration of the past year. So Cecilia, why don't we start with you? Thank you.
As Christine mentioned, I've been asked to reflect on the broader public health context within which the COVID pandemic has emerged in India. So my comments are not based on current research on COVID in India, but are rather based on my longer term ethnographic fieldwork on healthcare among low-income communities in South India. And I'd like to thank Christine and Shireen and Jishnu for including me in this very important conversation today. In 1995, low-income, lower-caste Dalit women birthing in Tamil Nadu, South India, did not receive anesthesia during birth unless a cesarean section was necessary. Even in Chennai's largest government maternity hospitals, anesthesia was only available for cesarean sections because there were not enough anesthesiologists to provide pain relief to the majority of women. In that year, many women would not go to the hospital for their deliveries, partly because although the services were ostensibly provided free of charge in public hospitals, in reality, women had to pay multiple small bribes to the medical staff to be admitted, to receive medical care, to receive food, to go to the bathroom, and even to have a hospital bed in a context where many were sleeping on the floor in overcrowded ante and postnatal wards. These endless bribes added up to significant cost for destitute people who could call a non-biomedically trained hereditary midwife to their home for a much lower price. Others refused to go to the public maternity hospitals because of the disrespectful treatment that they felt they received from the medical staff because of their class and caste status. They reported facing verbal and physical abuse for calling out in pain during birth without anesthesia. Doctors would tell them that if they screamed out like that when their husbands wanted to have sex with them, then maybe they wouldn't even be in the position of enduring the pain of birth. They faced incessant pressures to undergo sterilization if they were giving birth to their second or more child. If they refused sterilization, they were routinely inserted with IUDs immediately after birth, even sometimes without consent. These things deterred many women at that time from going to public hospitals for birth. Most could not afford private hospitals, so they birthed at home. A decade later, in 2004, I met a lab technician working in a public maternity hospital in Chennai that was designated as a hospital for implementing the government program to prevent HIV transmission from mother to child among poor communities. He complained that he was provided with only 2 pairs of gloves for each day. He used 1 pair to test multiple pregnant women for HIV and the other pair to do the laboratory analysis of all the blood samples collected each day. Pregnant women who came to these hospitals in 2004 and who opted for HIV testing that was recommended had to go to nearby pharmacies to purchase their own syringes and bring them back to the hospital for tests. Although this was done because the hospitals did not have enough syringes for this HIV prevention program, the patients were told they had to purchase their own syringes so that they would learn the importance of not trusting the use of needles unless they knew they had not been previously used by others. Also in 2004, I met HIV positive women who were rejected from hospitals because of their HIV status when they arrived in labor. They were told that the hospitals did not have the necessary PPE for medical staff to ensure universal precautions to protect themselves from HIV while facilitating births. In some cases, women went to 3 hospitals in labor and had to pay staff bribes in order to finally be admitted. In one case, after being admitted, medical staff refused to care for a woman when they discovered her HIV status, leaving the woman's mother to oversee the birth herself. Still another decade later, during my 2015 and 2016 research on cancer prevention and treatment for lower class Dalit women in Tamil Nadu, women were complimentary about the quality of the medical treatments that they received in the only tertiary care hospital, government hospital specializing in cancer care that was located in Kanjipuram. They used the state's medical insurance program for people living under poverty to receive standard cancer treatments, chemotherapy, radiation, and surgery for free. Yet many had to travel long distances to come to this hospital, some traveling 12 hours by train and much longer by bus. They would have to stay in the open wards of the hospital for 3 full months, sometimes longer if the radiation machine was under repair, during which time they were unable to provide much needed paid and unpaid labor for their families. Women in this government cancer hospital were afraid to ask the medical staff questions about the medical care that they were receiving because the doctors would speak disparagingly towards them, call them ignorant, and say they couldn't waste their time with such explanations. Patients told me that, quote, in private hospitals, we pay for the truth, but in government hospitals, they will never tell you the truth. And, quote, in private hospitals, you can be bold. It's all about money there, so you can be bold, unquote. But in the government hospital, they had to remain silent and deferential when receiving free medical care. One woman said, quote, the doctors stand far away from us when they speak to us on the ward, as if they think we are contagious, unquote. Most of the lower class Dalit women I met could not afford to pay for cancer treatments in private hospitals, even with the government insurance scheme. Those who had some means to do so tried that approach first, thinking they could get better care. I met a Dalit woman whose mother suffered from symptoms of cervical cancer for months without telling anyone or going to the hospital because of the embarrassment and shame, and because she felt she couldn't take time off from her work as an agricultural wage laborer. When the symptoms got so bad that she could no longer hide them from her family, they took her first to a small private clinic near the village. That clinic referred her to a government hospital in a nearby city. But the family wanted to avoid government hospitals because of their reputation for mistreating people like them from rural Dalit families. Instead, they took her to another private hospital where the mother was diagnosed with cervical cancer, an intensely stigmatized disease in India. The doctor there referred her to either the government cancer hospital in Kanjipuram or the nonprofit Cancer Institute in Chennai. But the family wanted to keep the stigmatized cancer diagnosis secret and so avoided going to a specialty cancer hospital. Furthermore, both cancer hospitals were very far away, so the family decided to take the mother to a different private hospital closer by, but still 3 hours one way by bus. By the time her mother was admitted into that hospital, her symptoms were severe. The mother had to stop chemotherapy treatments after 5 sessions because she became so weak. She was sent to another private hospital for radiation therapy instead. The family took out a large loan and went into deep debt for the chemotherapy and radiation, but ultimately could not afford to continue the treatments. Eventually, they took their mother to the Cancer Institute, where qualifying patients receive subsidized care. Whereupon, the doctors told them that the mother's cancer was too advanced to cure and that they could not admit her to the hospital. They scolded them for bringing her to the hospital so late. The family returned home and her mother died 5 days later. The family was not allowed to cremate their mother at the village cremation grounds because they were Dalits. Like other members of their caste community, they were forced to cremate the body in the fallow fields outside the village. With access to regular PAP and HPV screening and basic oncological care, cervical cancer is a treatable cancer. Yet 25% of all women who die from cervical cancer in the world are Indian. By now, you may be wondering if you've come to the right panel, as this is, of course, a panel on COVID-19. The second wave of the COVID-19 pandemic in India has been a traumatizing nightmare of epic proportions. Many people listening in today are likely grieving the loss of loved ones to COVID in India or self-isolating in their homes in India, fearful of getting COVID or other respiratory diseases without being able to access even oxygen or a hospital bed. Having money to pay for the best care in private hospitals or to bribe someone for access to a private hospital bed no longer guarantees good health care within medical facilities that are overrun and medical resources depleted by the magnitude of this crisis. Some Hindus are shuddering at the thought that if they or their loved ones die, they may not receive a proper cremation, as cremation grounds are overwhelmed with COVID deaths. These are heart-wrenching existential anxieties. Many of my professional academic friends and colleagues in India say they feel that they are left to fend for themselves. They describe this as a dystopian time, and it is a very apt description. My point of sharing snippets of my 3 decades-long ethnographic research on healthcare in India is this. People living in poverty, especially lower class Dalits, experience some version of this dystopia as part of their everyday chaotic encounters with the gutted out public health system in India. The vignettes that I presented above are not anomalies of worst case scenarios. They are all accounts of people from Tamil Nadu, a state with one of the best public healthcare infrastructures in India. There is no question that the current BJP administration and Prime Minister Modi should be held accountable for dropping the ball on COVID precautions and claiming India's victory for the fight against COVID for political gain when the first wave appeared to be tapering off. By holding huge maskless campaign rallies and allowing millions of Hindu pilgrims to gather for the Kumbh Mela in April 2021, even after repeatedly denouncing the Tablighi Jamaat for holding the smaller but nonetheless super spreader gathering of Muslims in March 2020, Modi's actions worsened the public health situation in India. The Western media too perpetuated the idea that India had somehow miraculously been spared the worst in the COVID pandemic, as analysts scratched their heads, claiming that COVID was mysteriously vanishing in India. Nonetheless, I believe that the bigger problem has a deeper history that cannot be attributed to one political party alone. It is the neglect of the public healthcare system in the wake of India's move to privatized healthcare. There was one passage in Arundhati Roy's April 28 piece in The Guardian calling the COVID catastrophe in India a, quote, crime against humanity, unquote, that I found particularly compelling. She wrote, quote, "This is what happens when a pandemic hits a country with an almost non-existent public healthcare system. India spends about 1.25% of its gross domestic product on health, far lower than most countries in the world, even the poorest ones. Even that figure is thought to be inflated," unquote. According to Seema Christie's May 15 article in The Hindu, the government of India reduced allocations for health even further in the February 2021 budget, even during a global pandemic. During the 21st century, India has continued its shift from a socialist model of healthcare for all to a neoliberal model of health insurance. In February 2018, the government of India's budget for 2018-19 included for the first time the Ayushman Bharat plan to provide health insurance coverage for families in poverty throughout India with up to 5 lakh rupees, which is today the equivalent of $6,857 US per qualifying family, to be used to access healthcare in the private and public health sectors. Although poor patients appreciate such insurance schemes, they have undermined the quality of public hospitals by diverting more public funds into private healthcare and health insurance institutions. The lack of funding for public health is not the only problem contributing to the disaster unfolding in India today. Just as we consider the role of systemic racism in the COVID pandemic in the US, we should also consider how the discrimination that lower class Dalits experience within the health system may have contributed to the second wave in India. When I heard reports in February that the coronavirus seemed to be vanishing in India, I thought about all of the people I met over the years who cannot afford private hospitals, but who are loath to go to public hospitals because of the disrespectful care they receive due to their class and caste status. Many will avoid seeking healthcare at all because of this. Others avoid seeking healthcare because of the cost and distance required for transportation to access public healthcare far from home. Others avoid seeking healthcare because of the stigma that they may face if they are found to be COVID positive. I have met Dalit women who complained about being asked to get tested for HIV or screened for cancer because they feel that everyone always assumes that they are diseased and contagious simply because of their caste status. They refuse to be further subjected to such indignities through testing. The stigma of disease can ripple through families and communities in India, ruining future marriage prospects and family prestige. Many feel it is better not to know. Even if it does come to be known, many feel it is best not to give a name to a stigmatizing disease in sickness or in death. These factors, among many others, have no doubt contributed to the undercounting of COVID cases and of COVID deaths that led people to prematurely relax public health measures at a time when a particularly contagious B.1.617 strain emerged. So these are just some of the many concerns that I have as a medical anthropologist. And I know my colleagues, Shireen and Jishnu, will have much more to say about this crisis from their perspectives as health economists. Thank you.
Thank you so much, Cecilia. I think that was really informative. And I think it does cast quite a bit of light of some of the social justice issues that this disease is exposing in India. Shireen, you are next.
Thank you so much, Christine, and thank you, Cecilia. You're right, India was ill-prepared to deal with this pandemic. You have rightly reminded us that for the poor, there really wasn't much of a healthcare system even before the pandemic. And yes, the several successive budgets have not prioritized health, including the most recent one in the middle of the global pandemic. The virus has exposed inequities and social injustices wherever it's gone. That has happened in the United States, as you pointed out, in the UK, in Italy. In India, it feels different. Maybe the inequities are particularly stark. Maybe the indignities of the caste and the class are particularly serious. It feels different. It feels bigger. It feels more intense somehow. The images coming out of India are gruesome, right? The official estimates are ridiculous. They're too low. They don't fit with the lived experience of most Indian people, including people abroad. The scale of this pandemic, I don't know anybody. I work in 10 states. And at this point, I don't know anybody who's not impacted by the pandemic. And the official estimates just don't fit with that lived experience. They're probably undercounts by a very long shot. According to some, they're, the real death count, the real case counts are anywhere between 4 and 10 times higher than what are being reported. So I agree with you. The images coming out of crematoriums are in some sense the best data we have, the death counts coming from those places. I wrote an opinion piece in CNN today. It was a little heartfelt, saying those images are really hard to watch and they're really offending, infuriating Indian people, right? They remind us of a colonial time when the Western gaze on the funeral pyre always felt judgmental. And in it is lost this kind of shared experience of what this virus has done worldwide. Having said that, I admire the effort to count the dead, even if it's in crematoriums, because what else are we supposed to do to understand the scale of this pandemic? Science, data collection is the ultimate tool with which we're going to fight this going forward. And that is where we're getting data right now. So, that as an economist, this reality of relying on data from crematoriums feels extraordinarily painful to me, at least, because it was not always this way in India. The country with that has lost count of the dead was once the country with one of the world's most sophisticated systems of data, or one of the world's most sophisticated data infrastructures, I would say, right? And it's shocking that we don't have the platforms, the collaborative systems, the kind of the culture of evidence-based policymaking in a country that pioneered those things um, just after independence. So this process has been going on for a while. Scientists warned after the first wave that there was a danger of false optimism. Um, they were not heard. In January 2021, the government's own scientific task force stopped meeting. It was disbanded. In March, the reports of the dangerous mutant strains by the Indian group, the SARS-CoV-2 Genetics Consortium, INSACOG, were unheeded. Nobody really knows what happened to the trail of paperwork that was delivered to the government by this group. In addition to ignoring scientists, the government has also restricted access to data. Now, Jishnu is going to show us some data that he's working with at the state level. But at the national level, on the 29th of April, hundreds of Indian scientists signed an open letter to Prime Minister Modi blaming the second wave on, the reality that epidemiological data was being systematically collected, but not released for analysis to anyone other than, government experts. They also complained that, ICMR data, the Indian Council of Medical Research data from COVID-19 diagnostic centers is regulated by government experts, right? That is not available to them for analysis. The principal scientific advisor to the government of India acknowledged the letter and also acknowledged that they were making a very valid point, but they did not yet release the data that they are asking for. The government has had an anti-science posture for a very long time. There are science conferences where university administrators argue for the use of scripture as scientific evidence. They challenge the work of Isaac Newton and say, gravity should be renamed, gravity waves should be renamed Modi waves. I mean, the ridiculousness of this, I shouldn't belabor the point, but, an overtly nationalist government controlling data is a problem at the time of the pandemic for us to be able to combat the spread of the illness. The issue has been, that this dismantling of the scientific infrastructure, it's not sudden. It's been going on for a long time. It hurts, again, because after independence, even before the political boundaries of modern India were decided, you had people, scientists like Mahalanobis, P.V. Sukhatme, working alongside the government to set up sophisticated surveys. The national sample surveys were the world's first large-scale surveys to use the method of stratified random sampling. Health scientists have advocated for the most modern systems of data collection and succeeded in persuading the government. That's how India dealt with leprosy, dealt with HIV, polio. I mean, India has done well, even on these limited budgets that you've reminded us of, Cecilia, and even with the lived realities that you're describing. In those health centers in Tamil Nadu were some major breakthroughs against polio, HIV, leprosy in the past, few decades. So I would say that the weaknesses of this data architecture have become glaringly obvious, but the dismantling of the systems of data collection have been going on for before the pandemic. The NSS, for example, every so often you see this play out in the Indian media. You know, the great Indian poverty debate boiled down to the changing in the language of a questionnaire, where the recall period of food changed from 1 month to 1 week, and that suddenly led to a magical decline in Indian poverty estimates. This happened in 2004. Again, GDP numbers, unemployment numbers. There was an unemployment report that was covered up for an entire, election season to avoid accountability on job creation. So reliable information has been hard to come by in India for a while. And it's at odds with the culture of the country in some sense, which has always prioritized data collection. I would also say, as a microeconomist who works on health, I have struggled to better use Indian population surveys in the past 20 years. They are irregularly administered, they're partial in coverage, the questionnaires and protocols keep changing. Any demographer or social scientist has to work 10 times harder these days to even construct a simple trend line for a simple thing like, death rates, mortality rates. The surveys do not gather information on non-communicable diseases. We have no cause of death modules that the World Health Organization has been asking India to do for a decade at least. So only about 20% of Indian deaths, even before the pandemic, were being assigned a cause of death, right? That's not something that's new in India. This inadequacy, unreliable data system is new. The Millions Lives survey, which actually studied cause-specific risk factors and mortality rates in India, recently documented how the causes of death in India were actually dramatically different than what official reports had been suggesting for some time. So, for example, road accidents, snake bites were claiming far more lives, according to the Million Lives survey, than we had ever known from the population surveys of India. So, again, I would say the current crisis, yes, the biggest problem is it's being managed by ideological politicians, by bureaucrats whose first instincts are to avoid data and rely on legal frameworks, institutional mechanisms, administrative structures. The scientists have been sidelined. The data they are being given is not of the highest quality that it could have been. And that, I think, is a really big challenge. People are talking about health budgets, people are talking about foreign aid. If you bring the scientists back into the fold and revive the culture of data collection, collaboration, and evidence-based policy, the worth of that is so much more than any foreign aid or even health budget can fully account for. So I think what I want to end on is saying, the images of funeral pyres and journalists camped out in crematoriums is infuriating, it's heart-wrenching, it feels unfair, it reeks of a certain Western media bias, if you will. But in some sense, that's happening because of the weaknesses and the of the data systems and the dismantling of the data architecture. And really, what the side effect of this is, the more you get images from crematoriums, the Indian politician calls out Western media bias and discredits the entire scientific endeavor of counting the victims of the pandemic, and thereby insulates himself. I will use himself here because I'm talking about a very small group of people, insulates himself from accountability. So bad data, limited data, images of funeral pyres, and an empowered politician who discredits the entire narrative as unreliable and shrouds himself in, official estimates that are far too low. They're laughable. And that's what I'm worried about, the kind of broad political economy of the whole data debacle. I'll stop there.
Thank you so much, Shireen. So we're now going to turn to Jishnu, and after his presentation, we will open it up to Q&A. Please use the Q&A function at the bottom of your screen. And I believe, Jishnu, you have slides that you're going to share with us as well, right?
Thanks, Christine, and thank you, Shireen. Shireen just emphasized where I'm going to land up again towards the end of my talk. But let me just start this talk with two or three quite simple stories or thoughts. Uh, and I'm going to do this by asking three questions. And you should feel free to write this in a piece of paper. I currently can't see the Q&A. Oh, I can, since I'm sharing my screen. But you can put it in the Q&A. But just don't think too much about these questions, right? So here's my first one, which is, suppose one sick person infects another 3. After 10 generations of infections, how many sick people will there be in the population? That's my first question. And just put down a ballpark number that you're comfortable with, right? And then think of a second question, which is, suppose one sick person infects another 4 instead of 3. After 10 generations, which is, the sickness goes on and on, how many sick people will there be? Again, just, put down a ballpark number. It's easy to calculate. You can just go to a calculator and do it, but don't do that. I mean, just put down whatever number you think would be reasonable, right? So these are 2 questions I wanted you to think about. Then I want you to think about 2 more questions. One is India's age-adjusted case fatality rates before the April 2021 surge. That's, way before 2020. We're talking about June 2020 or April 2020. Was it much lower than Italy's during its surge? And we know that Italy was really bad in the Lombardy region. Was it about the same, or was it much higher? My final question, during the April 2021 surge in Delhi, so this is what we're talking about right now, where we saw desperate situations, and some of you might have been, part of the whole diaspora and Indian groups who were up every night searching for hospitals and hospital beds and oxygen for people. I know that was my regular routine every night from 10 to 2 for a month. The state expanded its bed capacity in 2 weeks by, I'm going to give you 4 options, and I want you to think of the fact that New York City increased beds by 50% over a couple of months during its surge, which was a Herculean effort, right? So for Delhi, was it not at all? Was it by 20 to 50%, by 50 to 100%, or by more than 100%? So these are my kind of 4 questions that kind of frame my presentation, and just write them down in a piece of paper. Entertain yourself, entertain us, and we'll come back to them. So take 30 seconds. Let's wait. Hey, and thanks for posting on the Q&A. Okay, so you had a chance to do that. So let me tell you 2 to 3 things that we are uncovering about the surge, and then let's land up at a place. I want to leave it open for the discussion of kind of what do we do and how do we think about what happened in India, particularly with regard to what's going to happen in the future. I'm going to show you 2 pictures. This is Pakistan, right? So I've been working in Pakistan a lot, and let me show you a couple of things. One is the first surge happens from March 1st till about here. That peak is important because this is when Eid happened, and we were all really worried as we were tracking this that Eid was going to blow it up. It didn't. Immediately after Eid, the cases came down, despite the fact that everybody had commingled in large groups. In every city, the cases just vanished, right? Some people think that this is because, this was because there was less testing, and people have gone on record saying that, we have the microdata, we've been working with the microdata throughout. Testing during this time is basically going up, 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 up. So first of all, I just find it irresponsible when people say things without knowing the data. But, you should be aware that during all of this time, testing in Pakistan has been going on. Okay, so then it hits here. August 8th, again, things stay low for a while. And then there's a second surge, and we again start thinking, oh my goodness, this is going to become really bad. You know, the government starts getting really worried, and boom, it goes away again. Right? And then in April, around the same time as India, well, actually a little earlier, March, it starts surging again. But again, by June, it's gone, right? Or coming down sharply. So that's the Pakistan experience, and which is our neighboring country, you know, and by the way, this is completely out of step with what was going on in India. India kind of surge, you know, India starts its second surge. The first surge is really here and goes down, stays low, second surge here, and the third surge starts off here, right? But let me show you what India looks like in comparison. That's India. This was Pakistan right here, right? Those tiny numbers there. And this is India, right? Now you could say, now you can compare, right? I mean, this August 8th, which is here. So India surges right here, right? When Pakistan is at a low point, and Pakistan's surge has come before. And what you see in India is this last surge is unprecedented. There was nothing in the data, say from Pakistan, which we're tracking really closely, which said this second surge wouldn't be like this. Maybe it'll be even smaller than the first surge, right? And frankly, there was no epidemiological model out there that said, we lifted our lockdown here. This is a period of no lockdown. The surge has gone away. It's not going up, right? There's no epi model without herd immunity that would predict this, right? So at the first instance, we don't have a good idea for why the cases disappeared. And they disappeared. Again, we have micro testing data. We know that wasn't because they were not testing. The cases genuinely disappeared, and they came back with a vengeance. So what happened? So in the first surge, if you look at the first surge, so this is, 2,000 people who were infected in Punjab, India during this time. And this is a network graph, and we're basically drawing how many people all these others infected. And you see that this one person here infected quite a few. And these are all people who infected at least one person. There are a lot of people who infected only one person, right? And you might think that this was because they only met one person. In fact, that's not the case. When you estimate this whole thing out and you say, per person you met, how likely were you to infect someone else? The answer is that in the data from Punjab during the lockdown, so it's pretty good data, about 70% of people were infecting 0 other people, right? And this was not only India, this was everywhere. So one of the things people kept talking and the media kept talking about the high infectiousness, but the fact of the matter was all that we knew from all the data about household infectivity in the first surge said that if you were infected, the likelihood that your spouse was going to be infected was somewhere between 5 and 10%, right? And this is despite the fact that this was in 7 published papers by June, it was never emphasized by the media, right? So one thing that was really characteristic of that first surge was not necessarily the transmissibility, but what people call K, which is how much is the heterogeneity in transmissibility? Are there some people who infect a lot of people and others who infect nobody? And the answer is yes. In that first wave, 70% of those who were infected were not infecting others. The problem was when B1.617, which WHO now calls Delta, the variant that was first discovered in India, came in, it quickly became the dominant variant, right? This variant has higher transmissibility. So as India starts, there's very limited genome sequencing, but to the extent it's there, in March, B1617 was 1% of all cases, was being discovered in 1% of all cases. By mid-April, it had gone up to 50%. By end April, it had gone up to 80%. So this new variant just swept the population, right? And now coming back to that original question, suppose one sick person infects another 3, after 10 generations, how many sick people will there be? Well, the answer is about 59,049. But if one sick person infects another 4, so we're talking about 25% increase, the answer becomes 1 million. Right? What seems like a small increase in transmissibility, you use powers, you exponent it up, which is what's happening here. You see a 20-fold change in how many people are going to be infected. And that's one thing that no one realized, that a small increase in transmissibility can completely change the dynamic of the pandemic. And here, I don't mean epidemiologists, they recognize this. But at no stage was the question asked, what is the likelihood that a mutation will arise that will have a 25% increase in transmissibility? Right? There's nothing we can find in the literature pre-surge that says, hey guys, watch out for this, because 3 is 59,000 manageable, 4 is 1 million not manageable. Right? How will we know if this is happening? What should we do if we detect this? None of these questions were being asked. None of these questions were being answered. Instead, what we got right at the beginning was, even as the surge starts off, policymakers and politicians say, well, it's okay because we know that the older people got infected last time, so they must have herd immunity. And frankly, not too many people are dying because the case fatality rates are low. This is because Indians are special, so we don't need to worry about it. But again, the fact of the matter is, even with our undercounts of mortality, which are pretty severe, our case fatality rates far exceeded that in Italy during its surge. So this is from our first wave, when we did not have a huge problem in our hospital. So let me just show you those numbers. So here's, so if you look at older people in Italy, our case fatality rates, say in Maharashtra, were roughly similar to Italy's during the surge, maybe even a little lower here. But look at the 50 to 59 and the 60 to 69 and the 40 to 49 group. We were exceeding Italy's mortality rates during the surge by 3 to 4 to 5 times as much. And why does that really matter? That really matters because most of the people in India who were being infected, there is nobody in that 70 to 79 and 80 plus group, because only 5% of our population is greater than 65. So most of our population is here. In fact, this is 60, 70% of our population is right here. Right? 30% of our population is here. There's like less than 0.5% of our population is above the age of 79. So the fact that we had these huge mortality rates, even from the first wave, when hospitals were not overwhelmed, was telling us if something happens, we are going to be in big, big trouble. Right? But that was completely ignored. This is in the public literature. This is published in the Hindustan Times. You can follow the link. It's published in a note at the Center for Policy Research, where we've been regularly putting out these notes. But our health minister said that, well, no, the case fatality rates in the second surge are going to be really low because we know not many Indians die from this. Right? Third question, what did Delhi do? What happened in Delhi? Take a look at Delhi. So Delhi, this is, say, April, and our first surge comes to an end around here. Delhi's regular number of beds is about 5,000. right? That's what it has on average. During the surge, it builds up bed capacity to 15,000, right? But once that surge vanishes, which is around here, it's constantly seeing only 5,000 beds being utilized. Just as comparison, in the US, hospital bed utilization runs at about 65%. So Delhi sees 33% bed utilization all the way between July and December. And by now, these guys are stuck. They're like, why do we have 15,000 beds that we're maintaining at huge costs to our budget, which is under massive strain as it is, when we are getting 33% bed utilization, right? So in January, they take the decision to slowly reduce that. And for February and March, it pays off. We have 5,000 beds and 1,000 people in hospital. And then in April, it goes horribly wrong. So April 1st, 30% bed utilization. April 15th jumps up to 80%. May 1st jumps up to 99%. And we know that this was bed utilization. There was a huge shortage of beds during this time. But look at what Delhi managed to do. Delhi managed between April 1st and April 15th to push up its beds by 300%. Something that New York never managed to do, something that in China, when they built the hospital, there was huge news about it everywhere. Delhi managed to do that 5-fold over in 2 weeks. Right? The amount of work and the amount of surge capacity that these guys managed to do was absolutely unprecedented, right? And you see now the flip side of that. So what happens next? From 5th May to 23rd May, bed utilization in Delhi drops from 100% all the way, say in Delhi government facilities, drops all the way down to 15%. Delhi is now back in the boat of saying, well, what the hell do we do now, right? Sorry, I'm getting some weird things. What the hell do we do now, given that we have so many beds and nobody's in it? Do we continue to maintain this or do we drop it? Right? So what I want you to realize is these were hard problems that could not have been solved in the moment of the surge. So I think about this really as a pandemic of willful ignorance. And let me give you three and these are my final 2 slides. So let me give you 3 particular thoughts on this, and then we can perhaps move to the discussion. Christine, am I okay on time for 2 more minutes? Okay. So the question that I think we should all be debating and thinking about is what should have been done differently if we did not have the benefit of hindsight. So I want you to think about that. I want you to think about, you are the chief minister of Delhi. You don't have a lot of budget. You've spent tons of money protecting people during this time, giving out food, giving out a bunch of stuff. You've been maintaining your hospitals now for 9 months at 300% extra capacity. The epidemiologists have no model out there that says the surge should have vanished and you should have had such low cases. You're not seeing cases in the population. You've been testing regularly. Half your budget is going doing this testing. What do you do? Right? So that rules out, for instance, thinking that we could have predicted the surge or that Delhi could have acted very different during the surge. Given the lack of advanced planning, this was next to impossible in terms of hospital capacity, but not so in terms of lockdowns, right? So we're back in 3 areas that we really need to think about. And each of these areas for me is a failure of the central federal government, not the state governments. The first is, and I'll talk about this in 2 seconds, are there permanently at risk districts that we could have identified beforehand and put in special situations. The second, which I think should have been done right from the beginning, but should have been supported by more broadly by the scientific community, was do we have permanent restrictions on large events till we have 70% of our population vaccinated? Right? And let me bring up one thing there. There were elections during this time, and the Election Commission refused to change the election timeline or even to reduce the length of the elections to take care of COVID, right? And remember, so for example, I'm on the Global Advisory Board at West Bengal. The Election Commission rules are really strong, right? So I know of some states that couldn't even give food to citizens during this time because it would violate EC rules. The third is our vaccination strategy was a mess, and this could have been predicted. There were many, many missteps, much of which has been written about. But one thing you should know is by this time, we had given out about 120 million doses. That's enough to cover every Indian above the age of 45. Again, India is a young population, right? So these are three areas that I think could have been thought about before, and two of these are pretty obvious. Let me just talk briefly about one. And again, comes back to what do we think about data? So here, and this is going to be in a note coming out at the Center for Policy Research. I can send it along once it's ready. What we have done here is we have said, let's look at that first wave and let's look at the districts that were badly affected, right? That first wave was highly concentrated. So 75% of the cases happen in about 145 districts. That's 15% of all the districts in India. There's 718 in India, it happens in about 145, right? 50% of the cases happen in 45 districts. And what you can ask is, well, are these the districts that were less likely to get a wave in the next round, which is what epidemiological models of herd immunity would suggest? Because after all, if you got hit in the first round, you have all these people with herd immunity, you're going to get less affected next time around. The answer, surprisingly, is not. These districts constantly accounted for 75% of all case share until January. And then as the surge hits, which is here, they account for 85 to 90% of all cases. Right? Maybe 145 is too high a number to care for, but 45 districts, right? They account for 60% of all cases during the surge, right? So again, this is stuff that we could have done. There's no reason why, this is me, Partho Mukhopadhyay at Center for Policy Research, Shamindra Nath. So, why two economists, a social anthropologist and a geographer should be doing this is unbelievable for me, right? So for me, the big questions here is, do we have a system of actually thinking about the production and use of data and evidence? And I want to take Shireen's question of, do we have the data, to move further with, even if we had the data, do we have the systems in place to adjudicate and understand what can be done with that evidence? And if we discuss this, my answer would be no, and it's getting worse. So let me stop there, Christine, and hand it back to the panel.
For that, Jishnu. That was, really fascinating. So I'm going to just use the moderator's position here just for a second. So when COVID first became evident, that this was going to expose inequities in healthcare systems wherever it went, as Shireen noted, many India watchers were really concerned about the Kachi Abadis. I don't like to use the word slums, but I guess that's the word that people do use, like Dharavi in Mumbai. And they seem to be largely spared. And it's absolutely baffling that they would have been so spared. Is there a good explanation? I mean, this, speaking to Shireen's point and to Cecilia's point, I mean, this is a population that one would have gathered has very poor access to healthcare in general, the conditions in which they live, there is no possibility of social distancing, basic hygienic facilities are not available. What's the reason? Like, why were they generally spared? And then what happened in this wave? Did they remain spared in this wave? The media hasn't, I mean, there was a lot of reporting about the RV and so forth, but then when this wave hit, it fell relatively silent.
So I'd love to hear Jishnu's thoughts on it, but very quickly, I would say, Christine, as we saw, coming out of the first wave, Indian leaders were pretty good role models of scientific advice in the sense that Modi himself wore a mask. Any phone number you called, you got an earful about the importance of social distancing, hand washing, etc. I feel that coming out of the first lockdown, there was paranoia in the country about COVID and a real commitment to following rules and protocols, if you will. Something changed. I think, there are images of leaders putting away masks, refusing masks, convening mass gatherings. I actually think those elections and the Kumbh Mela will go down in history as some of the worst mistakes by any political leader anywhere for inviting people to these events. And the people from the slums are probably not the first in line to go to either one of those events, right? So that's my need. I don't have evidence of this, but my sense is that the successes of the first wave continue. My hypothesis is the successes of the first wave, the behavior change may have protected those places. And it is the people who fell for the political messaging and were sensitive to the political messaging, and Harshvardhan declaring the pandemic being in its end game, who fell prey to this wave.
Jishnu, do you have any thoughts about how some of these most, in so many ways, precarious communities were spared?
I mean, so first of all, it's not that these communities don't have good healthcare, because they are in the cities, they have access to better healthcare, even though it might be more expensive. I mean, Mumbai in particular, the municipal corporation has a long history of being able to manage this stuff, right? Mm-hmm. They have had to deal with all kinds of things all over, and Mumbai didn't do badly in the second wave either, right? But then during the first wave, the seroprevalence studies from that state say something between 50 and 60% of slum residents did get the disease. But remember that 40% of them left and walked back home, right? Mm-hmm. Out. And in the second wave, they actually feel that it was the high rises and the community buildings that got really badly infected, leaving aside the poorer communities. So, I think it's a combination of, there was a serious attempt, there was, as Shireen said, enormous fear and caution on part of the population. And the government did a fairly good job, right? I mean, allocating patients, getting this done, moving through Dharavi. I know Daksha, who's the epidemiologist, not the epidemiologist, she's one of the people who was doing this stuff. They worked hard. I mean, look, I think one thing that this did make clear was, for all the failures of leadership at the central level, I have never seen government officials work so hard for such a sustained and long period of time in my life. I mean, these guys are—
I agree.
24/7 for a year now. They are exhausted.
I agree.
I'd like to just echo what Jishnu is saying. And again, I haven't been as directly involved in this as a researcher as Jishnu and Shireen, but that has absolutely been my observation, is that for all of the problems in the public healthcare system that I sort of traced out through ethnographic examples, the public health workers themselves at all levels have been on overdrive, even, even before I think that became a major crisis in India. They began to, sort of organize as best they could. I also would say that, what we're seeing now is among the lower income communities, the problem is becoming more severe in rural parts of India, where there is, as Jishnu said, in major cities, there is better access to public health care. But in rural areas, this is where we're seeing major problems. I don't have the numbers, but based on my conversations with people working in the public health sector at the rural level, it's becoming much more difficult to manage. And so that's something I think everybody is sort of watching and very concerned about right now.
So let's turn to the Q&A. So there was one interesting question that came up. Why wasn't there like a Dr. Fauci-like figure that came to the fore in India? That's from one of our audience members. Anyone want to take that?
So I don't know. I would argue there are lots of Dr. Fauci's in terms of talent, right? Dr. Sanjay Oak in Maharashtra. I mean, look at the American pandemic. You have Indian faces all over CNN every single night, all through the pandemic. They were weighing in, Ashish Jha. I mean, India doesn't lack expertise. We are good at science, and the scientists are out there. Indians have innovated. Pool testing was an Indian innovation, right? Like the scientists, they're in the labs, they're doing. I think what is missing is an institutional platform where they can speak independently. I don't know, Jishnu, what you think of this, but to me, it seems like a lack of inclusion in evidence-based policy making that is at the heart of it.
In fairness, I think that was the gist of the question, given, as you noted, all of the expertise, why wasn't there a platform given to one or more of these experts? Jishnu, did you have anything, or Cecilia, to add to that question?
I mean, I think we've always been an argumentative society, and we don't give up easily on contestation around knowledge. So it's unclear to me that we have ever ceded authority to a central figure on any of this. Always been along the lines of argue it out. So what I find interesting is even now there isn't any consensus on what the treatment protocol is, right?
True.
For those of us who have been intermediating between patients in India and doctors here, one of the things we get is their prescription list, which usually contains like 16 medicines, leaving everybody here horrified. But there is no consensus, and we don't even have a way of moving forward on it.
Right.
So, and I think part of that was exacerbated, Christine, by the fact that these choices were not easy. Right. So even within the US, it's not that Dr. Fauci is a universally loved character. Right.
You think?
I mean, I have some sympathy for the memes that, went around saying Dr. Fauci says vaccinated people can now safely talk on the phone with their masks off. It's like, okay, but in India, that's pretty severe because you have, first of all, you have serious competing risks in terms of health. So if you're going to be locked down, what's going to happen to our TB patients? What's going to happen to our other, patients? And interestingly, all the interviews we were doing in slums at the beginning, everybody was saying, look, in terms of health risks, this is nothing compared to what we face every day.
Yeah, that's true.
I mean, the bigger risk here is I'll die of tuberculosis, I'll die of starvation, I'll die of diarrhea, I'll die of typhoid, I'll die of 10,000 other things. COVID as a health risk for poor people is very minimal, was very minimal in that first wave, right? Compared to 10,000 other competing risks. The second part is there was and is a serious trade-off between livelihoods and income, which is, and lives in India as opposed to the US. So in the US, I think that trade-off is just mistaken, right? In the sense that unless you get rich people comfortable to go out and shop and spend, you're not going to get a recovery, right? But in India, that's a serious concern. I mean, it is a really, really serious concern if day laborers cannot do their work. So I think the combination of the fact that we don't have any, there's no central public health department. We don't like people making statements on our behalf, right? We don't have a leadership that is open to anybody else sharing the spotlight, and that there were serious issues with, how do we trade off livelihoods and lives here? What do we do with competing risks on other illnesses? All of which would have required a deliberative forum for consensus statements to be made. And even to date, we don't have that.
So Jishnu, I mean, on this issue, can you go back when we were, before the panel formally commenced, we were having a discussion amongst ourselves about the harassment of journalists using very strict national security laws to punish journalists who are basically trying to engage the science over some of the propounded cures, such as covering oneself in cow dung. Of course, another popularly promoted cure is the drinking of cow urine. I mean, I presume, there's probably a lot of folks with ties to South Asia. This is nothing new. There have long been institutes dedicated to finding curative properties of these substances. In many households, particularly in rural areas, it was considered purifying to wash your home in cow dung. So these alleged cures, they don't come out of anywhere, right? The BJP didn't invent them, but they are what's what I'm looking for. They're sort of privileged myths by the BJP, right? The MP from Bhopal, Sanghvi, saying that cow urine and cow dung helped cure her breast cancer, left unstated, was in fact all of the medicinal treatments apart from those that she had also received. So can you talk about some of these arrests, what it means for trying to disseminate more appropriate treatments for this disease?
So I kind of feel that this will be more up Cecilia's training and expertise than mine. But a couple of things, I don't find it very different from ivermectin, right? So ivermectin is—
Yes, of course, exactly.
And there is a court case against Soumya Swaminathan, who is the chief scientist of the WHO, claiming that ivermectin has not shown impact in clinical trials, right? So I think the bigger problem is we haven't ever had a discussion about how are we going to adjudicate this. So, sure, look, all kinds of drugs are discovered by application of herbs, local folk remedies, which we don't know about, including artemisinin for malaria, right? Or quinine, right? But the fact of the matter is we haven't said, okay, if you really think that, let's do a clinical trial.
Right.
Now, is it that we don't believe in clinical trials? If we don't believe in clinical trials, what is that going to be replaced by, right? And I find that amazing because for almost 1,500 years, what India's elite was doing was setting up rules of debate and discussion. So the Nyaya Buddhists are all about what exactly is an argument. And there's specific rules for argumentation. So where did that all disappear? And what is that to be replaced by is now now a serious crisis, because we seem to have departed from all our traditions.
That's right.
in this direction.
But, being sued, right, for claims about one proposed treatment over another is one thing, right? But being arrested under national security laws is a really different matter, right? This is more of, we want to silence an opinion rather than adjudicate the opinion.
The
Right.
shutting down of debate, though, Christine, by discrediting the other side as being backed by some sort of foreign money, has been going on
Absolutely.
for the past couple of years. Just before the pandemic, the farm laws, right? There were people who were supporting farmers. And, okay, so there's a lot of foreign support for farmers. You can debate that out. How much do they know? What is their level of understanding of the deeper issues of Indian agriculture sitting in Canada or the United States or England? That's a fair question. But
In
what
fairness,
tended to happen is arresting people
Right.
who were protesting those laws within the country, arresting Indians who were protesting, saying, oh, your organization got foreign money. That was new. As Jishnu's saying, the India I know well is an India where there's chaos and debate and dissent. Prime Minister Nehru in his Freedom at Midnight speech was interrupted, right? And by a dissenter. They read the constitutional debates of India. There's a guy who interrupts pretty much everything. That person is never kicked out. That person has a place. And to arrest the dissenter is something terrifying and new to me. I agree.
Yeah, I mean, that's
also,
something.
I also think that this does become, caught up in very vehement nationalist politics, especially when it comes to not only issues that you're talking about cow urine, but also different, use of Ayurvedic medicine. And this has been an issue that predates COVID, of course, in terms of people with claims for cures for various diseases. Even in one of my earlier research projects on HIV/AIDS, there were many people who were claiming that they had found a cure, an Ayurvedic cure for HIV/AIDS. And one of the things that sort of bolstered the arguments of some of these Ayurvedic practitioners was what Jishnu was referring to. They made claims that they were sort of repeatedly making pleas for clinical trials that were being denied. And so that in a way, it sort of fed into this narrative of big pharma, sort of imperialistic. Big pharma is shutting down traditional Indian medicine. And that, if anything, added to the sort of cultural capital of some of these practitioners. And so I think that, these are things that we've seen played out for a long time prior to COVID as well.
So there are a bunch of interesting questions in the Q&A. I think a lot of them have already been cited. Gauranga, and I'm sorry, this is in this range where I'm really visually impaired, so reading these texts is really challenging. Gauranga Das has several questions about the scientific evidence for the curative properties of cow urine and cow dung. I think Jishnu talked about this. There's nothing a priori more dubious about these proposed cures than there is ivermectin, or I will add, injecting bleach into an available orifice, or for that matter, a UV light. I mean, we might have an a priori reason to reject bleach, many reasons, but the issue is, Mr. Das, is Jishnu addressed, is that there's no clinical trials for this. And because of the politics around these cures, anyone questioning it may now find themselves under very severe penalties of a law that was never intended to shut down this kind of debate, right? Is there anyone else that wants to add any further adumbration to this person's question?
I mean, can I complicate this a little further, Christine?
Yes, that's why we love you. You're the
So-
complicator.
So, that Indian Bar Association case against Soumya Swaminathan is really worth reading.
Okay.
As a textual analysis, right? Thinking seriously of that case material as a text. What I find very, so medicine has always had this problem of moving from the population to the individual, right? I mean, the RCT is a population-based trial. It's saying on average in this population, it tells you nothing about what that medicine does for you. And what's interesting is in those case files, the examples they gave are of 3 patients who were going to die, but then took ivermectin and were then fine, right? So what I find interesting is, there are problems with RCTs. And in fact, there's a wonderful paper out of MIT showing that the people in the US who were against lockdowns, people very much on the, Trump, MAGA kind of groups, they were not using lack of evidence. They were using equally sophisticated visualizations and graphs and evidence as people on the side kind of things to make the case, right? So I think we are back to look, I don't feel that there's a universal adjudication that will satisfy everybody, right? And part of the creation of knowledge is the contestation that happens around how it should be adjudicated. Right? Medicine has always had a problem of the all crows are black, kind of how do we move from the population to the individual? Now, how seriously are we to take those? How do we open up those debates? And what allows for some authority to be ceded scientifically to something, right? Because ivermectin is exactly the same. It's the fight over the population versus the clinicians, right? The doctor saying, I see this is helping my patient. Why should I care about a clinical trial? And fair enough. This is why so many drugs are allowed. All drugs, once they're approved by the FDA, can be used off-label for exactly that reason. Right? So there's a confusion here. I mean, it's not as if any of these questions are clear-cut. Right?
But I would even
at the end is that the configuration of we're never going to have a clear-cut question, but we have lost the framework for debate around these issues. And that for me is a huge loss relative, especially in a country that was built for philosophers arguing for 1,000 years on what the rules of debate are.
But I would say another thing, Jishnu, that, to some extent, this loss of platforms to adjudicate is happening across the world. Social media is the new platform on which people debate many ideas without evidence, right? In the United States, with that Christine's comment about, bleach being injected, that was a good example of this. In the end, it was the vaccine that arrived and in some sense has become the go-to of kind of getting out of this issue. I think, but now the debate is shifting to vaccines, right? The efficacy, the kind of, there's a whole anti-vaxxer movement, which is arguing without evidence that death is being covered up, and Pfizer and Moderna are part of some sort of big conspiracy to. So this is a never ending, but I think what's happening in India is extreme, but to some extent it's happening everywhere. And in the US, what you see is the arrival of the vaccine put a lid on some of those early debates about therapeutics. But one criticism of the Western response to the pandemic is we didn't fully adjudicate therapeutics and we went directly for kind of vaccines. And the lion's share of budgeting and debate was all on the vaccine front rather than the therapeutic front. And that's where India is also, getting hurt.
Yeah.
Cecilia, do you have any thoughts on this? You've been quiet for the last several minutes. Oh, you're muted, Cecilia. Oh, there you go.
Yes, I mean, I think that I do think that we have seen many of the same kinds of kind of anti-scientific arguments that have been used around therapeutics now targeting vaccines in the United States, since you sort of ended on the conversation about what is happening in the United States. And so while we do have, you know, Dr. Fauci, he is certainly not the leader for all when it comes to scientific information. And so, you know, to have people now saying that the vaccine is, you know, going to damage my DNA without any scientific basis for that, and yet people will state that very affirmatively as if they have that sort of scientific evidence at their back. And so I agree that this is, you know, this is an issue of sort of a global pandemic of its own in terms of the sort of misinformation. And I don't know how we address that as on a global scale. It's hard to see that we will, you know, not be living with that for a very long time, especially given the ways in which many people get their information through social media. So I wish I were more optimistic on that note, but I do think in the Indian case where, you know, where people can be arrested from putting up posters is, as both Jishnu and Shireen have noted, is really a very extreme kind of policing of information and of, you know, and of questioning, of sort of questioning accounts that are unscientific.
So is this, do you think, Cecilia, any different from other trends that we've seen about political knowledge and people sort of being able to kind of vertically integrate themselves into information streams that align with their priors, as opposed to, I'm thinking, I'm going to age myself here, but when I was a kid, we had 60 Minutes. We watched the news that we needed to know, not the news we wanted to know. And with the fairness doctrine being dissolved, we've had all of these other news channels that do not, they are not encumbered by the truth. They are free to adopt a specific editorial view, and people can sort themselves into these markets. And I see sort of the same thing about health consumption. Increasingly now, when I go to my own physicians, a lot of them have signs that says my medical degree is actually means that I know more than your Google search, right? So it seems to me that there's this is more similar than not with the other breakdowns of our societal fabric. And we're all cognitive misers, right? So we're going to trust people. We're going to take the advice of people that we trust. And unfortunately, trust in so many places has been politicized by, you know, political alliances or political allegiances rather than an adherence to fact. I mean, certainly from my point of view, this is a commonality across our public discourses. You know, when you look at India's media, it's sort of like Fox News on crack and bath salts. You know, it's really, and you know, you can sort yourself towards whatever message you want to see. Anyway, sort of blathering on here. So I think we'll wrap up. I don't want to be insensitive to the time of our panelists or for those that have tuned in from whatever time zone you're tuning in from. Thank you very much. Thank you, Shireen, Jishnu, and Cecilia. I've learned a lot from you. I don't know about others, but I certainly have. So thank you very much.